Injury to the right, injury to her upper arm while playing ice hockey. Examination shows diffuse swelling over the upper arm. The skin is intact. There is absence of wrist extension. X-ray shows a fracture of the distal humerus. Which of the following is most likely site of nerve injury? Proximal humerus. Distal humerus.
Ready?
1 second. Yes, ready.
Okay. So is radial nerve above the elbow. Radial nerve injury above the elbow. The radial nerve courses posterior to the humerus in the mid shaft within the radial groove. It is often injured in this displaced mid shaft or distal humerus fractures with resulting wrist drop. The radial nerve supplies motor fiber to the triceps brachii and the extensor muscles within the posterior compartment of the forearm and sensory fibers to the dorsum of the forearm, wrist, and hand. It does not innervate the intrinsic muscle of the hand. Injury to the nerve at the mid diaphyseal or distal humeral causes extensor muscle function loss at the hand and fingers, weakness of supination, um, presence of wrist drop, and sensory loss over the dorsal forearm, dorsal hand, and dorsal thumb, index, middle, radial half of the ring finger. It's not a distal humerus fracture will cause radial nerve injury above, not at the elbow. Okay, next.
So radial nerve above the elbow, like if there is wrist drop, then radial nerve above the elbow. But if the lesion is within the elbow, then wrist extension will, then wrist drop will not gonna occur.
Oh,
Am I
okay.
am I said right?
Yeah, I think so. I think you got it. Yeah, I think you get it. Yeah. They sent that. I think they sent that the
Yes.
radial groove. The radial groove where the radial nerve passes is. Let me see where it is. They're saying that it's not really at the elbow. It's like a little bit above it. Of the humerus.
Next. Oh, you are finding something. Okay. Yes.
Right. You see the this is the elbow. I'm guessing.
Yes.
Wait, I think so. No, never mind. Yeah, this is
Yes.
the
This
elbow.
is yes.
And the and the
What
radial
happened to you?
sorry. And the radial groove is up here.
Yes.
So there's that is
Yes.
not at the elbow. Yeah, I think that's what they're trying to say. Yes. Okay. Next. Next.
An 82-year-old woman. Sorry. 82-year-old then. Okay, gender is not a problem. 82-year-old man is admitted to the ICU for ICU after undergoing an uncomplicated elective sigmoid colectomy for chronic diverticulitis. He is extubed and rates his pain as 2 on a 10-point scale. He has a history of coronary artery disease. His medications are atorvastatin, metoprolol, aspirin. His temperature is 37.2. Pulse is 110 per minute. Respiration 32 per minute. Blood pressure 140/80. Pulse oximetry 6 liter per minute. Pulse oximetry on 6 liter per minute of oxygen by nasal cannula shows oxygen saturation 92% the airways, jugular venous distension. Expiratory wheezes are heard at both lung bases. Which of the following is the most likely diagnosis? Heart failure. Is it heart failure?
I don't know, but I don't think so.
Raised GBP.
GBP and then expiratory wheezing. I don't know. Maybe
Or after the surgery, or it is P.
I'm thinking PE, but it
There
doesn't
is
really.
no hypotension, tachycardia,
Uh,
tachypnea.
if it
Saturation
does,
is low. In PE, JVD is distended. Is there anything like that?
yeah, JVD is distended, but there is no hypertension here. Um, but the other things don't make sense. The pneumonia don't make sense. MI, he
Yes.
doesn't have any chest pain. He says he doesn't have pain. And core pulmonale, you wouldn't hear it. I mean, I don't, maybe,
Why wheezes, expiratory wheezes?
I don't
Maybe P. Okay, let's see.
know. Oh, it was heart failure. This patient is displaying classic signs of acute congestive heart failure. These include tachycardia, tachypnea, hypoxemia, jugular venous distension, and end expiratory pulmonary wheezing, sometimes referred cardiac wheeze because of the association with pulmonary edema resulting from heart failure. Other signs of congestive heart failure can include shortness of breath, dyspnea and exertion, apnea, production of fortis sputum on the left, yeah. While right side heart failure is characterized by increased jugular venous pressure, hepatomegaly, ascites, blah, blah, blah. Anesthesia and surgery place significant stress on the body, and MI demand, and myocardial demand can exceed cardiac output, especially in older patients with underlying coronary artery disease. Additionally, surgery is complicated by blood loss, and fluid shift may result in the need for administration of several liters of like blood and product. Treatment of an acute exacerbation of congestive heart failure consists of diuresis, respiratory support, and in more severe cases, intravenous positive inotrope and ventricular assist device, blah, blah, blah. Core pulmonale describes right ventricular failure resulting from chronic pulmonary hypertension. Left ventricular contractility and afterload are not affected. The patient is not displaying signs of right heart failure, I guess. And then it's not PE. What is PE? It presents with acute onset dyspnea, chest pain. It doesn't have chest pain. Symmetric lower extremity edema may be present, indicating the presence of DVT. Recent surgery is a risk factor for venous thromboembolic disease, and a large embolus can cause obstructive shock due to right ventricular failure. However, the patient is not displaying signs of right heart ventricular failure. Okay, okay.
Yes, next. So it's as due to presence of classic feature, that's why it is CHF.
Mm-hmm.
Okay. A 30-year-old woman A 30-year-old woman has had frequent palpitation and dyspnea with mild exertion for 2 days. She underwent an aortic valve replacement for rheumatic heart disease 2 years ago. She is receiving warfarin therapy. Her pulse is 80 per minute, regular blood pressure 140, palpable. She has pale conjunctiva. The lungs are clear to auscultation. Prosthetic heart valves. Prosthetic heart sounds and loud systolic and diastolic murmur are heard. There is trace edema of the lower extremity. Hematocrit is 24% with numerous cystocytes and fractured erythrocyte. Leukocyte count is 14,000 and X-ray of the chest show cardiomegaly without redistribution of the blood flow. Which of the following is the most likely cause of this patient's condition?
Ready?
Mm, mm, okay,
This dysfunction of the prosthetic valve. This patient presentation is most concerning for dysfunction of the prosthetic valve. There is a large difference between her systolic and diastolic BP. Increased pulse pressure, which is best explained by significant aortic insufficiency. This is further supported by the presence of diastolic murmurs and trace pedal edema. During exertion, the backflow of blood results in cardiac output that is unable to match metabolic demand, counting for this. And the presence of anemia and schistocytes is suggestive of valve-related hemolysis, which is a complication of prosthetic valves often caused by structurally degraded misposition or leaking valve. Okay, next.
yes. One day after undergoing open cholecystectomy, okay, one day after undergoing open cholecystectomy, a 47-year-old man has increased blood pressure and moderate abdominal pain. She was not taking any medication prior to the operation. Post-operatively, she has been receiving lactate ringers solution and patient-controlled morphine with a bolus dose of 1 milligram and a maximum dose of 6 milligram per hour. There 6 milligram per hour. There is 10 minutes lockout interval and no basal rate. She has been given nothing orally. She is alert, cooperative. Temperature is 37 degrees Celsius, pulse 115 per minute, respiration 22 per minute, shallow. Blood pressure is 170 by 90. Pulse oximetry on room air shows oxygen saturation 95%. There is no there is no jugular venous distension. Cardiopulmonary examination is normal. The abdomen is soft and moderate tenderness and movement produce pain. Bowel sounds are absent. Which of the following is the most appropriate next step in this patient's hypertension? Mm, 1 minute. Yes, ready.
So it is increased bolus of morphine. Appropriate pain control is important in preventing postoperative complication. This patient has abdominal pain associated with hypertension, tachycardia, and respiratory splinting. The latter of which puts her at increased risk of diastasis and consequent pneumonia. Patient controlled analgesia is frequent use option for controlling postoperative pain with opiate analgesics such as morphine. Typical patient control anesthesia PCA setups include basal rate, bolus dose with a lockout interval and total hour. Benefits of PCA include to improve patient satisfaction, titrability, and decrease risk of sedation. Even the frequent small boluses as compared. However, PCAs are associated with an overall increase in opioid usage. Basal rates are rarely used as they can be associated with increased respiratory depression and overdose. Therefore, they are often reserved for opioid-tolerant patients. Thus, in these patients with signs of uncontrolled postoperative pain, her bolus of morphine should be increased. It's not CND. Sorry. IV furosemide is not indicated in the patient. She demonstrated no signs of volume overdose, such as JVD or peripheral edema. Her hypertension is most likely secondary to uncontrolled pain rather than volume overload. It's not IV metoprolol, not necessary. Beta blockers such as metoprolol are used to treat hypertension. Tachyarrhythmia such as AFib, flutter, they are not indicated in this patient. Hypertension and tachycardia are more likely due to uncontrolled pain. Increase a bolus dose of morphine would be appropriate. Next step. Okay.
Next.
Mm,
A 67-year-old man, a 67-year-old man comes to the physician for a routine health maintenance examination. He feels well. Well controlled with he has hypertension well controlled with enalapril 5 years ago. He 5 years ago he underwent coronary artery bypass grafting. He smoked 2 packs of cigarette daily for 20 years but stopped smoking 20 years ago. He walks a mile ago. His temperature is 37 degrees Celsius, pulse 84 per minute, respiration 16 per minute, blood pressure 125 by 78. Cardiopulmonary examination shows no abnormality. Abdominal examination shows a non-tender pulsatile mass in the mid-abdomen. No bruise, heart, femoral pulses are normal. Abdominal ultrasound shows 4 centimeter aneurysm. There is no evidence of rupture. Which of the following factors provides the best rationale for serial imaging rather than surgical?
mm, mm. Is it the size or is it the absence of symptoms?
Uh, isn't it? We have heard like less than 5 centimeter is medical.
Oh, less than five. So it's the
I am
size.
just asking you, not
But
I'm telling.
I know there is
There
a
is
size.
like that. There is like
Yeah,
that about size.
there is a size. I just
But
don't remember what it
the
is.
symptom probably not.
Yeah.
Uh, I think so. But
Okay.
the,
Let's.
the, these days the CMS is very
Yeah, they're pretty
they,
complicated. Those surgery ones. Okay.
this CMS actually making me upset.
Oh, okay. So you're right. It's the size of the aneurysm. Uh, Triple A refers to dilation of the abdominal aorta more than 3 centimeters. Most commonly occurring in inferior, yeah, is often asymptomatic, although it can present with abdominal pain or hemodynamic stability if it breaks. Physical examination may discuss pulsatile abdominal mass and anticipation, but it can also be fine. Diagnosis is made with abdominal ultrasound CT scan. Risk factor for development of triple A include age, male, sex, smoking, vascular disease, connective tissue, whereas risk factors for rupture include smoking, hypertension, large aneurysm more than 5.5, and rapid enlargement more than zero point 0.5 over 6 months. When the risk of rupture is high, surgical repair is often recommended. If the risk of rupture is low, serial imaging is blah, blah, blah. Therefore, given this patient history, is more appropriate for him to undergo serial imaging rather than blah, blah, blah. Absence of symptoms is not often used in the decision process of AAA surgery. All symptoms may cause an aneurysm to be repaired sooner. Large, more than 5.5, and rapidly enlarging aneurysm, even if asymptomatic, should be surgically repaired due to the high risk of rupture and consequent mortality. And it's not C, never mind. Patient history of cardiac disease put him at risk for developing AAA. However, the risk for rupture is more closely related to ongoing hypertension and size. Okay, this patient blood pressure is currently well controlled, making the size of his aneurysm a more important aspect in determining whether he needs surgery. Okay, next. Next.
Yes, a 30-year-old male firefighter has been hospitalized 3 weeks for treatment of third degree 3 weeks for treatment of third degree burns involving the neck, upper chest, involving the neck, upper anterior chest, right upper extremity. A purulent exudate is noted at IV catheter site located in the proximal cephalic vein just above the left wrist. When the catheter is removed, additional purulent exudate drains from the site. Temperature is 38.7 101.7 degree Fahrenheit. Pulse is 115 per minute. Respiration 18 per minute. Blood pressure 105/70. Physical examination shows an 8 8 centimeter segment of the cephalic vein in the firm, tender, indurated erythematous fluctuant. In addition to IV broad spectrum antibiotic, which of the following is the most appropriate next step in the management?
Ready?
Yes.
So is excision of the vein damage.
Oh,
Catheter related,
you have given B, isn't it?
no, D as in dog.
Why heparin?
I don't know. Don't ask me. I'm just this MS is just not for me. This surgery thing is not for me. Just
For
don't ask
not
me.
B also. Okay.
Catheter-related bloodstream infections are a common cause of fever in hospitalized patients and can be complicated by catheter-associated thrombophlebitis, septic thrombophlebitis. Infected thrombus serves as a nidus for microbial proliferation and presents with fever, signs and symptoms of bacteremia. The involvement may display redness in duration, and there may be purulent drainage from the catheter side. Diagnosis may be by Doppler ultrasound or CT scan. Treatment of catheter-associated septic thrombophlebitis include infectious source control with removal of catheter and surgical excision of the affected vein. Huh. IV antibiotics should be continued and adjusted to microbial sensitivities when possible. It is not heparin administration or TPA does not have well-established benefit in the setting of septic thrombophlebitis and is not recommended in most patients. And you said B, you wanted B,
Yes.
okay. Elevation of the left arm and application of warm compress is inadequate for providing source control in the infected venous thrombus. Okay, okay. Next.
Okay. A 58-year woman A 58-year-old woman has had pain and tenderness of the long bones of the lower extremity, knees, ankles for 2 months. She has smoked one pack of cigarettes daily for 30 years. She was diagnosed with squamous cell carcinoma of the lung 6 months ago. She has had rheumatoid arthritis 15 years ago. She fractured her ankle in a fall 6 years ago. Examination of the lower extremity showed tenderness to palpation of the femur and tibia bilaterally, and slight warmth and tenderness of the knee and the ankle extreme. Shows periosteal newborn formation of the femur. Which of the following is most likely complication of this following? Still newborn formation করতে
Mm-mm-mm. Hmm. I don't know. Does she has osteoporosis? No, she has rheumatoid arthritis. Ugh,
Why there is formation of periosteal newborn?
I don't know. It doesn't make sense. I'm between.
This
This doesn't make sense. Uh, the only thing it cannot be osteoporosis. That makes sense. Rheumatoid arthritis wouldn't affect the whole bone. Doesn't make sense. Only thing that makes sense maybe something with the cancer. I don't know. I don't know why, but it may be something with the cancer. Oh wait, it's squamous cell. So
squamous cell carcinoma causes hypercalcemia. That's why.
so it's breaking the bones. I'm thinking. I mean, it makes sense. I don't know why there's periosteal formation, but I know it can break the bones and cause bone pain.
RA cannot cause periosteal newborn formation.
I don't think. I mean, mm,
Okay, let's see.
yeah. Let's see. At this point, I don't know. Surgery is just not made for me. Yeah, squamous cell carcinoma of the lung, often complicated by hypercalcemia caused by paraneoplastic PTH production. This protein acts similar to PTH, causing increased osteoclast activity, also cause increased absorption of calcium in the intestine and renal tubule. Bone pain is common manifestation. Other symptoms: abdominal discomfort, muscle pain and weakness, polyuria, site disturbance. Hypercalcemia is also associated with hypophosphatemia, subperiosteal bone resorption, nephrolithiasis, renal failure. Management is determined by the severity of calcium imbalance and symptoms. Asymptomatic cases are treated with oral fluid intake and reduced dietary calcium, while severe cases IV administration and medications that inhibit bone resorption like bisphosphonates. It's not. What else? Osteoporosis, low bone mass typically occurring in postmenopausal female. Prevalence increase with age. So you screen for osteoporosis at 65, after 65. Often asymptomatic until traumatic injury results in fracture. Involves the hips, radius vertebra. Though prevention of osteoporosis involves calcium and vitamin D repletion, hypercalcemia will be unusual complication. And then it's not the rheumatoid arthritis has clinical cause characterized by joint destruction, periarticular bone loss, and synovial hypertrophy, along with extraarticular manifestations such as nodule and skin rash. Joint pain is more common than pain in the long bones. Okay, next.
So
Mm,
how we will how we will proceed this question?
I don't understand your
Like,
question.
oh, what will I see? Like periosteal newborn formation.
Just forget the periostaltic information. At least it don't make sense here.
Okay,
Yeah,
you
don't.
just follow the exclusion.
No, no, no. Even the exclusion don't make sense here because I was also between osteoporosis and rheumatoid arthritis. Just yeah, don't do it. The exclusion don't work here. Uh, just go with the fact that she has squamous cell carcinoma, and you know that that causes PTH related peptide. That's all. That's all. Because the periosteal newborn is going to confuse you. It doesn't make sense. Even in the explanation, they don't say anything about periosteal newborn formation. They just said subperiosteal bone resorption. That's the one I know. The bone resorption. They don't say nothing about formation here. So I don't know why they put that on the question.
Okay,
Uh,
next. 6 days after APR, abdominoperineal resection of the rectum. 6 days after abdominoperineal 6 days after abdominoperineal resection of the rectum for cancer, a 62-year-old woman becomes dizzy as she walks to the bathroom. Mm, the post-operative course had been uncomplicated. Her temperature.
are you still there?
Yes, yes. The post-operative course has been uncomplicated. Her temperature is 37.1, pulse is 135, respiration is 34 per minute. Blood pressure is 120 by 70. She is anxious and diaphoretic. The chest is clear to auscultation. There are no cardiac murmurs or gallops. There is no tenderness or edema of the lower extremity. Which of the following is the most likely cause? Clear.
Ready?
Yes.
I feel like it's atelectasis. And I chose PE. Oh, it's PE. Thank God. PE refers to embolized blood clot to the pulmonary vasculature, most often from the veins of the lower extremity. Hmm. Symptoms include dyspnea, chest pain, hemoptysis, lightheadedness, syncope. Clinical signs is tachycardia, tachypnea, hypoxia, and information hypotension. These factors for DVT and subsequently include prolonged immobility, precoagulability, tissue injury, post-surgical DVT and consequently are common as surgical patients, especially those with malignancy. And many of the risk factors that put an increased risk of metastasis and clot formation. These often develop like 5 to 7 days after procedure, and prophylaxis with subcutaneous heparin is frequently instituted to prevent the formation. Thus, in this case, a patient with dyspnea, tachycardia, and tachypnea, 6 days following procedure B is the most likely diagnosis. Treatment is therapeutic anticoagulation. Atelectasis is unlikely to be the cause of patient's acute shortness of breath, tachypnea, and tachycardia. While atelectasis can occur postoperatively secondary to mobility and the effects of anesthesia is most commonly asymptomatic or presents with mild hypoxia. Dry inspiratory crackers on exam P is the more likely. Blah, blah, blah. Okay, next.
Yes. Next.
Mhm.
2 months after undergoing an orthotropic 2 months after undergoing an orthotropic liver transplant, a 47-year-old woman comes to the physician because of persistent liver and shortness of breath. He has recurrent pleural effusion since the operation requiring aspiration. The yield of fluid has been decreasing each time. His temperature is 38 degrees Celsius, respiration is 24 per minute, breath sounds are decreased over the right hemithorax. There is dullness to percussion. The remainder of the examination shows no abnormality. An X-ray and the CT scan of the chest are shown. Which of the following is the most likely diagnosis? Dullness. So, is it empyema?
Why? Because he has fever. Um,
If
what,
we look at the CT scan, these large big atelectasis we have never seen.
what
Atelectasis
lung?
means collapse of the lung, isn't it?
Uh-huh. And there is dullness to percussion. Dullness,
Dullness to percussion can be found if there is fluid.
decreased breath sound, blah, blah, blah. I guess if I, why is it not mesothelioma? It wouldn't look like that now. No. Mesothelioma would be just the pleural fluid, the pleural. Hmm. Okay, I guess let's go with empyema. That makes only thing that makes. Okay. But I'm still, I think it's between chronic atelectasis and mesothelioma. But let's see. This is
No,
so bad.
we are right.
It's empyema. You're right. We're right. We're right. Okay.
No, I am
Checks.
not right. We are right.
You're right. I probably would have just end up choosing something else at this point. This surgery is hard. Wow. The chest X-ray shows reduced lung volumes with a large region of consolidation and effusion in the right lung base and periphery. This is further reflected in the CT scan as a loculated heterogeneous fluid collection consistent with paima. Paima accumulation of fluids within the pleural space are commonly present with fever, progressive cough, and shortness of breath. Mhm. Patient has had recurrent pleural effusion following his liver transplant, likely due to regional inflammation and disruption of the right hemidiaphragm. Yeah, and pleural effusion is at risk of becoming seeded with bacteria, which may lead to empyema, frank pus in the yeah. This patient is at increased risk of infection from common and uncommon organisms due to immunosuppression related to organ transplant. Makes sense. Management of complicated effusions and empyema requires source of control with chest tube placement and drainage as well as antibiotics. It's not chronic atelectasis can have a variety of appearance on chest imaging depending on underlying cause. On CT scan of the chest, the collapsed portion of the lung parenchyma will frequently have more homogeneous appearance as opposed to the varying densities observed in these patients. Don't know what they mean. Okay, it is not the mesothelioma classically presents with chronic cough and shortness of breath. Malignant mesothelioma is associated with recurrent pleural effusion caused by inflammation and disruption of the pleura. However, calcified pleural plaque, okay, yeah, is typically observed on chest imaging. The history of recent surgery preceding development of, sorry, what is it? The history of preceding development if you make malignancy less likely. Yeah, there is no pleural plaques. Okay, next.
'A 16-year-old boy is brought to the emergency department after motor vehicle collision. He was not wearing a seat belt and struck his head struck his chest on the dashboard. Examination shows a fracture of the right arm, and X-ray of the chest shows minimal haziness in the right mid-lung field. An X-ray of the chest shows minimal haziness in the right mid-lung field. 48 hours later, he has a cough and crackles. He has a cough and crackles are hard on auscultation. He is afebrile. A repeat X-ray shows and confluent infiltrate of over the left and right upper lobes. Which of the following is the most likely explanation for this finding? Um, is it lung contusion or fat embolism?
Definitely not fat embolism. I'm between, okay, he doesn't have fever, never mind. And I'm between anaerobic pneumonitis and lung contusion. I think it's lung contusion. I don't know, in pneumonitis, do they have fever? I know they have cough, but do they have fever? Hmm.
Okay, pick one.
Okay. So it's lung contusion. Pulmonary contusions may occur after blunt or penetrating trauma to the chest. They often underlie the region of trauma to the chest wall and result from damage to capillaries with associated leakage of fluid into the pulmonary interstitium and alveolar space. This can result in hypoxemia if it involves the compromise a large enough region of the lung. On chest X-ray, pulmonary contusion appears as interstitial lymph trace or partial alveolar opacity. The extent and distribution depend on mechanism, location, and force of trauma level. Management of pulmonary contusion is supportive with pain control, pulmonary toilet, lung expansion, and maintenance of adequate ventilation and oxygenation of the patient. Anaerobic pneumonitis refers to acute irritant injury of the pulmonary alveolar and airways caused by inhalation of gastric contents. It presents similar to aspiration pneumonia with pain, shortness of breath, cough, but is distinguished from aspiration with pneumonia by lack of fever, though there is substantial clinical overlap in the presentation. Radiographic appearance is variable and may range from ground glass opacity to consolidation. Aspiration pneumonia, fever, cough, productive of pulmonary sputum, malaise, chest discomfort following an aspiration event. Frequently, aspiration occurs in a dependent position of the lungs, such as lower lobes. Focal consolidation is visible on X-ray. Okay, next.
An obese 37 an obese 37-year old man is brought to the emergency department 30 minutes after being involved in a motor vehicle collision. The restrained front passenger. he was he was a restrained front seat passenger. His pulse is 90 per minute. Respiration 24 per minute. Blood pressure 110 by 70. Ecchymosis are visible over the mid-abdomen from the lap belt. A nasogastric tube is inserted. An X-ray of the chest shows an obscured left hemidiaphragm with the tip of the nasogastric tube in the lower left side of the chest. Which of the following is the most likely diagnosis?
Tip of a nasogastric tube,
Hmm,
side of the chest.
it is obscured left hemidiaphragm.
Mm,
Obscured left side, right?
no,
It is
no.
rupture.
It doesn't. I feel like they're trying to tell us something, but I'm not getting it.
The nasogastric tube is inserted. Where it goes? It goes.
It's gastric, so you should go to the esophagus and then the stomach. But
Yes.
it says that they're
It,
finding it
it, they found
in
it in the hemidiaphragm, isn't it?
no, they found it in the chest,
Chest.
in the chest. So it didn't go to the esophagus.
Lungs is from. Sorry. So esophagus to stomach.
So it didn't. Are are they trying to say that it didn't go to the esophagus, the stomach, it went to the chest? How to say what they're trying to say? If that's what they're trying to say, then are they meaning like they're trying to say esophageal rupture or no?
If esophageal rupture, why it is not like diaphragmatic rupture? Option CD is not the answer, isn't it?
I don't think so. No, no.
Is it either diaphragmatic rupture or esophageal rupture?
Yeah, I mean the question makes diaphragm. I mean they say something with the diaphragm muscule, so I'm thinking diaphragm rupture. But then it seems that they're trying to tell you something that the nasogastric tube was inserted, but it's found in the chest. So it seems like they're trying to say esophageal rupture, but I don't know. It just is it what they're trying to say, or I don't know.
I don't know
Okay,
actually. I choose diaphragmatic rupture. Let's
I'm
see.
not sure. Let's try not to overthink it. 'Cause, I mean, yeah, if we don't overthink it, we'll go with just diaphragmatic rupture. We'll just go with that. Yes, okay. Diaphragmatic rupture. Traumatic diaphragmatic rupture can occur after blunt trauma that causes a sudden increase in intra-abdominal pressure and leads to rupture of the diaphragm. An opening in the diaphragm can lead to herniation of abdominal contents into the thorax and often present with chest pain, shortness of breath, bowel sounds within the expected lung fields. Okay. Most commonly occurs in the left hemithorax and may be visualized as intestinal loops or other abdominal organs in the thorax on X-ray. In this patient, the presence of nasogastric tube in the left lower side of the chest raises. Oh, that's what they were trying to say. Okay, okay. Management includes surgical exploration and repair of the ruptured diaphragm. Esophageal rupture permits translocation of GI contents such as food, stomach acid, and bacteria into the mediastinum, which, if untreated, can lead to mediastinitis, chest pain, fever. The examination may discover crepitus over the chest wall or neck, and crunching sound may be heard on auscultation. Okay, next.
Okay. A 47-year-old man is admitted to the hospital for evaluation of 7-day history of fever and diffuse mid diffuse mild abdominal pain during the past 2 months. He has noticed increased abdominal girth. He has a long-standing history of alcoholism. His temperature is 38.5 degrees Celsius, pulse is 105 per minute, respiratory 16, blood pressure 135/82. Examination shows poor inspiratory effort. Heart sounds are normal. The abdomen is distended with mild tenderness throughout all quadrants and shifting dullness. Bowel sounds are decreased. Rectus examination shows no abnormality. Paracentesis is performed. protein 5.2, albumin 3.4, globulin 1.8, lymphocyte 3600, segmented neutrophil 68%, monocyte 18%, albumin 1.1, protein 1.1, albumin zero point 0.7. Each of the following is the most likely diagnosis.
We're doing the
There was a chart. If
I
protein
don't
is 1.1, like, uh,
the SAG one.
yes, yes,
Is SAG is will be serum aside serum ascites.
ascites, albumin
Uh,
gradient,
so it's serum one 3.4
yes,
over
uh,
0.7. So it's 4.8. So it's more than 1.1. So it will be
portal hypertension, isn't it?
okay. Yeah. Wait, more than 1.1 is portal hypertension.
Less than 1 point, isn't it?
I don't remember.
Yes, I think so. Let's jump into on that way. We will find something.
Either way, I don't think we need this here. He has fever, he has neutrophil high, and he has ascites. So shouldn't that just be spontaneous bacterial
Bacterial.
peritonitis? Or no? Or am I? That's two eaters. Shouldn't it be?
In SBP, yes, there may be fever. Yes, it can happen,
Yeah.
and there is high sag also in SBP. I was thinking about SBP, but I was looking for
So, okay. Let's see. Yes, SBP. Here we don't need, but that's definitely important. What was the higher than 1.1 was, oh my God, I feel like I just read that yesterday. Give me a second. Uh, okay, yeah. Yeah, I just read that yesterday. Is SAG, portal hypertension like cirrhosis, Budd-Chiari, and cardiac ascites caused by increased hydrostatic pressure, and then it will be less than 1.1. Wait, no. Ah, never mind. Wait. Portal hypertension is more than 1.1. Absence of portal hypertension, which is due to decrease on contact pressure, that's less than 1.1. Okay, never mind. This right here. Put this more than 1.1. You got it?
no.
Oh, sorry. I was saying that SAG, the SAG that we were talking about,
Yes,
for portal hypertension, for example, in cirrhosis, Budd-Chiari, and cardiac ascites, which is caused by increased hydrostatic pressure, the SAG will be more than 1.1.
yes. In here, sag is more than 1.1. So
Yeah, so it's portal hypertension. And when there is no portal hypertension, for example, in oncotic, decrease oncotic pressure is less than 1.1. And then, oh, the other thing that we know, the total protein in ascites, if it's low protein ascites, uh, then it's cirrhosis or nephrotic syndrome. So if it's low protein ascites, less than 2.5, it's cirrhosis or nephrotic syndrome. I don't think this is important. Yeah. But here we didn't really need that. SBP is the most likely diagnosis in this patient with history of alcohol use disorder, fever, abdominal pain, acidic fluid containing numerous neutrophils. SBP refers to development of peritoneal infection in patients with ascites that is not caused by instrumentation or introduction of bacteria into the peritoneum from alternative source. This patient most likely has cirrhosis from chronic alcohol use. SBP is common complication in patients with cirrhosis and ascites regardless of the cause. Portal hypertension leads to reduce intestinal motility within bacteria stasis and overgrowth, in addition to impaired GI immunity. Portal hypertension also causes gut wall edema. This confluence of factors can predispose to translocation of bacteria from the gut got lumen into the bloodstream or across the wall into the peritoneal cavity. This pathogen can see the peritoneal cavity, which in patient with ascites provides perfect raw medium for bacteria. Symptoms: fever, hepatic encephalopathy, abdominal pain due to sepsis. Signs and symptoms of sepsis. Risk is higher in patients with lower serum albumin concentration as and in those who have experienced prior SBP. Diagnosis is made by diagnostic paracentesis that show absolute neutrophil count more than 250 cells, which gram stain is not sensitive for diagnosis, but can but common pathogen include E. coli, strep, Klebsiella. Treatment is antibiotics, usually third generation cephalosporin, followed by prophylaxis with ciprofloxacin and TMP-SMX. Okay.
So in case of SAG, like if it is elevated high SAG, if it is elevated blood pressure, elevated portal pressure, then it is CHF, congestive heart failure, cirrhosis, portal vein thrombosis, and Budd-Chiari syndrome, isn't it?
Yeah.
And if it is low SAG, like portal pressure not elevated, if it is very low serum albumin, it is nephrotic syndrome. If there is peritoneal inflammation like malignancy, TB, pancreatitis, it is it will come with low SAG. Okay.
Mhm.
Okay. A 27 year, a 27 year. You want to take a break for 5-10 minutes?
Mm,
You have done your breakfast or not?
no, I'm not really hungry. I have a
Okay.
sore throat.
Okay. Then how you solve up to 30? Then we take break. Okay.
Okay.
A
Or
20.
up to 25.
Sorry.
Up to, or up to 25. And then we take a break.
Okay. Okay. A 27-year-old man comes to the physician because of 6 month history of intermittent abdominal pain and decreased energy level. The first episode of abdominal pain occurred after he ate a large meal. He then had an urgent need to move his bowels and passed watery stool containing bright red blood. At first, subsequent episodes occurred once or twice weekly and only involved abdominal pain. 4 weeks ago, he started to have daily pain. He started to have daily pain associated with bloody, watery stool. He has no history of serious illness, takes no medication. He visited Mexico 1 year ago. He is sexually active with one male partner and they do not use condom consistently. He appears pale and tired. He is 191 centimeter tall, weight is 83 kg, BMI is 23 kg per meter square. His temperature is 36.9 degrees Celsius, pulse 85 per minute, respiration 18 per minute, blood pressure 115/70. The abdomen is scaphoid with mild diffuse tenderness, no masses is palpated. Hemoglobin 9.3, hematocrit 29%, leukocyte count 7,800. Platelet count is 3 lakh 10,000. Anti-nuclear anti-neutrophil antibodies positive. Saccharomyces cerevisiae is negative. Which of the following is the flexible sigmoidoscopy and pseudopolyps are inflamed friable mucosa? Which of the following is the most likely diagnosis? Ready?
Yeah, sure.
Okay, let's see.
It it is UC. Alternative collected is the most likely diagnosis: young patient with chronic abdominal pain, weight loss, hematochezia. Colonoscopy shows fibrous mucosa and encephalopolis. UC results in inflammation and ulcers of the colonic mucosa, typically beginning with the rectum and advancing proximal. Symptoms range from mild to severe: chronic abdominal pain, weight loss, body diarrhea, abdominal bloating, tenesmus, Colonoscopy is gold standard, demonstrates inflamed mucosal and ulceration, sometimes in association with pseudopolyps, extending in a continuous fashion proximally from rectum. The presence of ANCA, a negative test for antibodies to SHAT, I don't know how to say that word, strongly argues for diagnosis of UC instead of Crohn's disease. Treatment depends upon the severity of symptoms and the extent of disease. Mild disease involving only rectum can be managed solely by 5-ASA enemas, while extensive disease usually require oral ASA medication and steroids and biologic and more things. It's not, I want to read the other one, yeah, I guess. Maybe dysentery is usually by entamoeba histolytic and present with subacute onset bloody diarrhea and abdominal pain. Stool PCR, microscopy, and antigen testing can all be used to make that. Colonoscopy showing continuous saturation, blah, 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 will be unusual. And then Yersinia is typically acute and subacute and presents with abdominal pain, fever, diarrhea. While bloody diarrhea does occur, this is more common in children and adults. Okay, next.
A 55-year-old woman vague had vague pain in the left lower quadrant of the abdomen for months and foul-smelling urine for 2 weeks. She appears thin. There is mild tenderness in the left upper quadrant of the abdomen. Rectal examination shows tenderness with no masses. Hematocrit is 29%. Urine analysis shows 50 to 100 WBC, 5 hyperfilled 4 plus bacteria. Urine analysis show greater than 10,000 colonies per ml and mixed fecal flora. Test of the stool for occult blood is positive. Which of the following is the most likely diagnosis?
It's where the left lower quadrant. Ready?
Yes,
Colon cancer. Colon cancer is most likely cause of this patient foul smelling urine, growing fecal bacteria. Positive test for occult blood in stool. Colon cancer is the third most common cancer in adults, most often present after age 50. Although patients with hereditary disorders or a positive family history of colon cancer frequently develop cancer at younger age. Colon cancer is colorectal cancer, one of the few malignancies for which routine screening colonoscopy can meaningfully change outcome. As lesions that are detected early are often curable, what patients who present with system referable either to the primary tumor or metastatic have worse prognosis. In the case of this patient, the presence of fecal flora in the urine, colovesical or other GI urinary fistula, which are developed following erosion of a primary colonic mass into the bladder. The concomitant presence of positive fecal or cord blood stool thence lends further evidence to the presence of colonic mass. While her thin appearance, the duration of her symptoms is he thin? Okay, okay. And a hematocrit suggests that the tumor has been present for 4 months and likely much longer. The next step in evaluation should be CT scan of the abdomen and pelvis with contrast and a colonoscopy. Treatment is whatever. It's not ulcerative colitis, chronic inflammatory condition within blah blah blah, results in inflammation and ulcers of the colonic mucosa. Starts in the rectum and goes up. Symptoms include chronic abdominal pain, weight loss, bloody diarrhea, abdominal bloating, tenesmus. The presence of colovesicular fistula will be atypical. There isn't one that causes fistula, or is it Crohn that causes the fistula?
yes, fistulating Crohn's.
Oh, it's Crohn. Okay, that's why I was confused. Okay, next.
I don't know how it is colon cancer.
Oh, they're trying to say because the blood in the stool, and she's old, blood in the stool, and she's losing weight. I forgot that one.
Where is the weight losing
Right
option?
here, they did it so small that I didn't even pay attention to it. Right here, it's like she appears thin. Yeah,
Sorry, I haven't seen. Sorry.
right here.
Oh, she appears thin.
Yeah, I didn't. I
Very
missed that.
minor detail.
Yeah, it's like I didn't even see it. Yeah,
That was the catch.
yeah.
A
Next.
68-year-old man has had an enlarging lump under his tongue over the past 3 months. The lesion is now ulcerated and somewhat painful. He quit smoking cigarettes 10 years ago. There is a mass adjacent to the inferior dental extending to the inferior surface of the tongue. Submental lymph nodes are palpable, but there is no neck adenopathy. Which of the following is the most appropriate next step? Okay,
Ready?
yes.
Mm. It's biopsy of the mass. Where am I? Oropharyngeal carcinoma is common and may occur in oral cavity, pharynx, larynx, or nasal cavity. Squamous cell carcinoma is the most common type and is strongly associated with tobacco use and HPV. Patient may present with oropharyngeal lump or nodule, non-healing ulcer, dysphagia, adenopain, weight loss. Establishing the diagnosis with biopsy is essential for management. Staging can be aided by cervical sentinel lymph node biopsy and imaging with CT or MRI scanning. Early stage disease may be managed successfully with surgical resection. Although more advanced lesions usually require a combined approach with surgery, radiotherapy, and chemo. It's not wide excision of the mass with radial neck dissection. Involves removal of primary lesion as well as involved lymph nodes, internal jugular veins, sternocleidomastoid, and spinal accessory nerve and parotid edema. This procedure reduces the risk of further metastasis pain. It may be appropriate. Oh, where am I? It may be appropriate for certain patients with suspected or established metastasis to cervical lymph node, which occurs commonly on pharyngeal cancer. Initial biopsy is necessary prior to proceeding for radical neck dissection because of significant mortality associated with the procedure. Okay,
Let's take a quick break.
okay.
A 67-year-old man remains intubated and mechanically ventilated 6 hours after admission. 6 hours after admission to the hospital for hematemesis, he has alcoholic cirrhosis, was brought to the emergency department 6 hours after he vomited a copious amount of blood. He has received 4 units of packed red cell. His current temperature is 37.4. Pulse is 105 per minute. Blood pressure is 130 by 75. Examination show peripheral muscle bursting. Cardiopulmonary examination shows no abnormality. The abdomen is moderately distended and non-tender. There is no fluid web. Hematocrit is 29. Placement of nasogastric tubules. Dark blood. Which of the following is the most appropriate next step in the management?
Hmm, 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 hmm. Debated.
It's this bleeding due to varices, isn't it?
I'm guessing even if he doesn't have fluid wave, but I'm guessing it's varices. So do we? And he, okay, they already inserted the. They did the A airway, B the bore. They already did it. C circulation. They did it. He's still unstable, so he's still bleeding. So do we do the surgical exploration or the EGD?
I think that like in variceal bleeding, we do endoscopic band ligation, isn't it? EVL.
But that's like 1 2 weeks after the thing has.
Like EVL is done 1 to 2 weeks after, or is it
Like
done
one,
emergency?
I think it's 1 to 2 weeks after. I'm
So
not
you
sure.
want to do surgical exploration.
Because it
Usually
seems
it is not done in the uh, liver cirrhosis. Do we do that? I don't
I'm,
remember.
I'm not doing it because it seems like he's still bleeding. He still says dark red blood.
But
That's
he
what
is
I'm
hemodynamically stable. Blood
stable.
pressure.
That's what
Yes,
I'm
that's why surgical explanation may not be that.
may not be. So then you think it's EGD.
Probably. I'm very
You're very confident about.
no no. This CMS is very
Okay,
unpredictable.
let's check. Yeah, it's EGD. Cirrhosis can be complicated by portal hypertension, which also leads to development of varices, gastric esophageal. That may rupture and lead to massive life-threatening hematemesis. Additionally, alcoholic gastritis, independent of cirrhosis and portal hypertension, is a common source of GI bleeding. In cirrhosis, obliteration of the hepatic sinusoid throughout progressive fibrosis increases the resistance of blood flow to the liver, which is blah, 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 causing portal hypertension. When engorged secondary to portal hypertension, esophageal veins can be visualized in EGD and vertical dilation on edema, representing dilated submucosal veins. Varices. Varices are usually treated endoscopically by ligation, and patients with cirrhosis must be screened for both identification of and the source and intervention to control the bleeding. This patient presents with hematemesis likely from rupture varices, gastritis, or similar upper GI source. It's not surgical exploration of the abdomen will be indicated in case of hemorrhagic shock related to traumatic blood or penetrating abdominal injury. The patient's bleeding is intraluminal, not peritoneal. Uh, thus, exploratory laparotomy will not be indicated. And it's not mesentery angiography will be helpful in cases of GI bleeding in the small or lower bowel. Small or lower. While not as sensitive as a radiographic erythrocyte scan, it permits direct visualization of contrast extravasation at the site of bleeding, which allow for definitive diagnosis. Definitive intervention with coil embolization. So that's for small bowel. Okay. Next.
A 77 year a 77-year old a 77-year-old man comes to the physician because of 4 month history of difficulty swallowing. 4 month history of difficulty swallowing solid and liquid associated with sorry. A 77-year-old man comes to the physician because of 4 month history of difficulty swallowing solids and liquid associated with gurgling in his throat. During this period, he has been walking. Sorry, during this period, he has been walking during the night because of coughing and has bad breath. He has not had any other problems. He underwent appendectomy at the age of 25 years and polycystic gallstone at age 50 years. He is currently takes medication. Examination today shows no abnormalities except for halitosis. Barium always seen. Which of the following is the most appropriate next step in the management?
Ready? Ready?
Yes.
Okay. So it's diverticulum. It's anchored diverticulum occurs within the hypopharynx, um, between the cricopharyngeal muscle and inferior pharyngeal constrictor muscle. Mechanism of formation includes an uncoordinated swallowing mechanism, which results in muscle spasms of the cricopharyngeus, leading to pulsion diverticula as the wall of the hypopharynx and superior esophagus weaken. Symptoms include halitosis, regurgitation of indigestive food, dysphagia, barium swallow reveals posterior midline outpouching above or at the level of the cricopharyngeus. Treatment includes surgical repair and resection as well as dietary modification to include soft or liquid foods. Okay.
Next. A 16-month-old boy, a 16-month-old boy was brought to the emergency department by his parents after they noticed a small amount of bright red blood in his diaper 2 hours ago. The boy awakened twice overnight, screaming as if in pain, saw the parents saw the blood after the second awakening. The patient ate well and was playing normally prior to going to bed. 10 days ago, he had an upper respiratory tract infection which resolved without treatment. On arrival, the child is sleeping and is difficult to arouse. Vital signs are within normal limit. A palpation of the abdomen discloses mild tenderness and mobile 4 to 3 centimeter mass. There is no distension. Rebound. Bowel sounds are normative. A small amount of blood and mucus is noted in the patient's diaper. The remainder of the examination shows no abnormality. An abdominal X-ray shows non-specific gas pattern. Which of the following is the most appropriate next step in the diagnosis?
Ready?
1 second. Ready.
This air enema with ultrasound into susception refers to telescoping portion of the intestine into itself, to the telescoping of a portion of intestine into itself, most commonly the ileocecal junction. Ileocolic, I'm sorry. Ileocolic junction symptoms include severe intermittent abdominal pain, emesis in hematochezia. Young children may be observed drawing their legs up during their abdomen, toward their abdomen during the pain episodes. Physical exam discloses a palpable abdominal mass. The susception can be idiopathic or occur at late points, such as area of inflammation of mecadiverticulum. The susception leads to venous congestion, which results in intestinal edema with subsequent ischemia and necrosis. Severe cases lead to intestinal perforation and peritonitis. More commonly occur children less than 2 years old. It is often preceded by viral infection. Diagnosis is typically made with ultrasound, which discloses target sign. Ultrasound can also be used in conjunction with air enemas, both diagnostic and therapeutic procedure, for intussusception that has not progressed to perforation. Next.
Yes. A 76-year-old woman is brought to the emergency department because of 3-day history of increasing abdominal distension and left lower quadrant tenderness. The patient has a history of Parkinson's disease. and chronic constipation medications are carbidopa, levodopa, and docosahexace, and enema as needed. Vital signs are within normal limits. The abdomen is distended and moderately tender. The abdomen is distended and moderately tender to palpation over the left lower quadrant. No peritoneal tenderness, masses, or hernia are noted. Results of the lab studies shows a leukocyte count 18,000 and abdominal X-rays shown. Which of the following is the most likely diagnosis? What is that?
Hmm.
Ready?
One moment. Diverticular abscess.
Because it
That
is left lower quadrant. One point for that for diverticular abscess, and there is a leukocyte count is high,
it doesn't have no fever.
but leukocyte count is high. May maybe fever is subsided.
Okay.
Other things does not fix.
That makes sense. Yeah, it doesn't make sense. Oh my god, I knew it was sigmoid. I knew it. I could see the thing. I was like, it just doesn't make sense. Oh my god, I could see the big shape. I don't know what.
Yes, now I can
Uh,
see too.
oh my lord. Okay. Yeah, because abscess they'll always give you the fever, and they make sure to say vital signs are normal. Anyway,
Yes,
sigmoid volvulus. This year
sorry
mess
for
is
that.
no. I mean, this year's mess is like full of like
These
very
these
weird
these
movement.
things does not look that type of coffee bean shape, but not
Yeah, it
typical.
doesn't, but it really does. I think this CMS is just full of little tricks. Like you have to read every sentence.
Yes,
Yeah,
including they are uh, teaching us we have to read every bit of the word in
yeah,
the exam.
yeah. Because remember the other question with the skinny woman, and we just missed the fact that she lost weight, so
Yeah,
we didn't know it was cancer. Yeah. Anyway. Sigmoid volvulus is to the cause of this patient abdominal distension and pain. The X-ray of the abdomen discloses grossly distended airfield color with a dense vertically oriented line that represents two walls of the colon. Coffee bean, I'm guessing, is this line. Various other X-ray features encoding Freeman-Dal sign, the presence of a distended colonic loop over the liver. I
these
don't know.
signs I have.
I've never heard of that.
Yes,
And the absence of rectal gas are useful in supporting diagnosis. Sigmoid volvulus result from twisting of the sigmoid mesentery, which can lead to large bowel obstruction and perforation and intestinal necrosis, blah, blah, blah. Patient commonly presents with symptoms secondary to large bowel obstruction, such as constipation, abdominal bloating, distension, nausea, vomiting. Patients without complications such as ischemia and perforation, treatment is the torsion of the sigmoid colon and mesentery to sigmoidoscopy with placement of a rectal tube to facilitate stool passage. Current sigmoid volvulus may require sigmoid colectomy. And it's not, what was that? Diverticular abscess may develop as a result of diverticulitis, which is infection of the diverticula. Symptoms frequently include abdominal pain, fever, sometimes localized peritonitis. Diagnosis is made using abdominal CT scan and abdominal CT scan. So you'll see fever. Next.
yes. It was a hospitalized 6-week-old girl with respiratory distress of the newborn has sudden episodes of apnea and temperature instability. Delivery was at 26 weeks of gestation. She has been exclusively fed with a cow-based formula. She appears pale and lethargic. Her temperature is 35.8 degrees Celsius. Pulse 160 per minute, respiration 64 per minute, blood pressure 65 by 35, capillary refill time is 6 seconds. Abdominal examination shows generalized distension and erythema around the umbilical stump. Ultrasounds are decreased. Lab studies show leukocyte count 32,000, segmented neutrophil bands, eosinophil 3%, lymphocyte 70%, platelet count 45,000, PT 30, PTT 70, and abdominal X-ray shown. Which of the following is the most likely diagnosis?
Jesus.
PT, PTT high, low platelet. There is formation of DIC.
Oh, he is a baby, preterm newborn. Hemorrhagic disease of the newborn. Malrotation. Malrotation will be too early. Omphalitis. I don't know what omphalitis means. Necrotizing enterocolitis. Yeah, because she's a baby. He's a baby. Okay. Ready?
Yes, what have you picked?
I think necrotizing because he's preterm.
Yes,
What did you okay.
I picked necrotizing.
Okay.
Preterm formula fed, like
Oh,
exclusively fed
formula.
with cow-based formula.
Okay. Necrotizing presents with decreased feeding tolerance, abdominal tenderness, distension, emesis, diarrhea, hematochezia. Most commonly preterm babies, especially those with very low birth weights. If a feeding tube is present, gastric residual volume may be high or there may be bilirubin drainage. In neonate, signs of severe systemic illness, shock include lethargy, temperature instability, apnea, hypotension, some of yeah. Lab evaluation will typically demonstrate leukocytosis, anemia, thrombocytopenia, signs of DIC with increased growth in tava. It's caused by necrosis of the intestinal mucosa, which allows the invasion of gas-forming bacteria in the bowel wall. Pneumatosis intestinale on X-ray. Necrotizing enterocolitis can progress to bowel necrosis, perforation, peritonitis. Treatment includes IV antibiotic therapy, bowel rest with fluid, gastric decompression. The surgical resection is for advanced case. I want to read another one. Okay, it's fine. Okay, we are done. We'll
Okay,
see you tomorrow.
okay, bye bye.
Bye.